Hi, good morning. It's a pleasure to be here. First of all, I'd like to thank the organizers of Symposium for inviting me to speak today. And I'd also like to say how much of an honor it is for me to share the podium with Dr. White and Dr. Eastwood, two real international leaders in children's orthopedics. Also, it's fun to see a number of patients and families in the audience. I've already said hi to a couple today, so it's great to see fellow clinicians and families and patients. So I'm looking forward to a great day today. So I thought today what we do is I first start off with, I have just a few, first of all, I should say I have no financial disclosures to mention. I do have a couple personal disclosures. And first of all, unfortunately, my talk is probably too long. I always like to cram a lot of information in these talks, so unfortunately I might go over my time limit just a little bit, but I'll try to be as courteous as possible. And unfortunately, I also have a tendency to talk fast, so I apologize in advance. But I thought the way I would approach the talk today was to try to look at this as far as looking at four of the most common questions that I get asked when I'm seeing patients with MPS. And I will start off by saying the majority of my experience is with MPS 1H patients, Hurler's patients. A number of these patients are referred to the University of Minnesota, and I work in collaboration with doctors at the University of Minnesota. I do have experience in the other MPS issues as well, but not as much as with MPS type 1. So I thought we'd do is we'd approach this by looking at maybe four of the most common questions that I get asked each day. First, I say, most people say, well, what is the hip issue in MPS? What are we talking about when we talk about sort of hip dysplasia in MPS patients? Second, if we talk about how we're going to try to change that, what are the approaches that we look at as trying to change or improve those hip issues? Third question is, can we do surgery safely? So if we're proposing a surgery, I'm recommending a surgery to a patient or the family. One of the next questions is, especially in this age of connectivity, the internet, people talking to other people on Facebook and chat pages, frequently they say, well, we've heard about issues and problems at other hospitals. How can you assure me or reassure me that we can do this surgery safely? And then lastly, and maybe most importantly, does surgery really make a difference? Are we really trying to improve, or can we improve the hip issues for these patients? So first of all, if we want to talk a little bit about what is the hip dysplasia that we see in MPS patients, what I have for you is an x-ray on the right side of a patient who does not have MPS, and on the left is a 2-year-old patient who does have MPS. I'll presume that most people in the audience are not orthopedic surgeons and maybe are familiar with x-rays of the hips or maybe not familiar with x-rays. For patients and their families, you've probably seen x-rays like this frequently if you've seen your doctors or seen orthopedic surgeons in the past. So on the right x-ray is a patient without MPS, and so this would be kind of the typical development of hips in a young patient who's 2 years of age. So one thing I'll just kind of explain when we think about the hip joint, again, just fundamentally we talk about the hip joint as being a ball and a socket joint or a ball and a cup joint. So the ball is what we would refer to as the head of the femur or the femoral head. So the femur is the thigh bone. So the round part of the ball at the top is the femoral head. And the hip socket, if you will, a hip cup, is what we would call the acetabulum. So the acetabulum is the hip socket. Okay? So in a typical developing hip patient, you see that the ball would be sitting in the socket on both sides. On the left, you have an x-ray of a 2-year-old with MPS 1H, and here we can see that the hip socket is much shallower than normal, has a much steeper appearance, is more vertical, if you will, and that ball is not sitting right down into the bottom of the socket where it belongs. It's actually out to the side a little bit. It's not centered right in the middle of the socket. One thing that's interesting we've noticed is that we've seen a few patients who are the younger siblings of patients who have been diagnosed with MPS, and so as a younger sibling, they get diagnosed, or they get treated, or they get tested at birth and diagnosed early. And a lot of times what we'll see is on, say, an ultrasound in a young infant, the ultrasound will still look normal. On the x-rays in a patient, say, less than 6 months of age, the x-rays will still look radiographically normal. So a lot of times these x-ray changes don't really become noticeable until somewhere around between 1 and 2 years of age for a lot of patients. If we now look at a patient who's age 5, a little bit older, a lot of times what we find is that the hip socket is still shallower than normal. And what's interesting about the hip socket in patients with MPS is that the hip socket looks abnormal on an x-ray, but again, this would be different than, say, hip dysplasia we see in children who don't have MPS. So it's a form of hip dysplasia, but what's kind of intriguing or interesting is that what we're really seeing is that this outer part, we call it the lateral part, the outer part of that socket, okay, or the outer part of that acetabulum, doesn't really form bone normally. So if you look at the hip socket, here's the ball again, the femoral head, here's the socket, and we see is out here in the lateral part on each side, there's like this little defect. So in a typical hip, the socket would actually come around like this, but the bony part would extend all the way out over the top of the ball, all the way up to over here. So one of the things we kind of understand about the bone issues in MPS conditions is that some of the effects are systemic, okay? It affects the body globally in all of the bones. But then it also says that there are certain focal areas where the bone doesn't form normally. This is probably one of the explanations why many of the kids develop the spine deformities and their thoracolumbar kyphosis. The vertebral body doesn't form normally. And in this outer part of the hip socket, we classically said this part isn't really forming bone. Now, in truth, there is tissue there. There's soft tissue that's out in here, and so the socket actually does extend out this way, but there's just not the bone development of the socket that supports that hip. And unfortunately, because that's not the normal bone development, over time, as children get older, it doesn't stand up to forces and pressures over time. Now, if we look at a patient who's age 14, for example, and this patient's had no previous treatment, now we can see further changes. So we can see again, so we have the shallow hip socket on both sides. Okay, so that would be the acetabular dysplasia. We see that the hip socket, or the ball, I would say, is out to the side. It's not completely centered within the hip socket. It's partially out of the socket, and so the term we would use is called a hip subluxation. So it's partially in, but partially out. So it's not completely centered in the socket. As children get older, they also develop this deformity of the femur, where the femur becomes more vertical, more straight up and down. Normally, this should be more of an angle here. So they get what we would call coxovalga. Oftentimes, this develops as children get older, too. So this is probably like a later development, again, when children are probably 10 to 14 years of age. We'll occasionally see in younger patients, too, but it's often when they get older. And then we'll oftentimes find this little area where they have this kind of medial area where it almost looks like the bone isn't forming normally. So a lot of times this would have the appearance of what we would call avascular necrosis, or this medial defect within the femoral head. And then finally, if we compare this again to another patient who doesn't have MPS, we can see again a classic X-ray or a typical X-ray on the right of a patient who has typically developing hips. And you look at the X-rays on the left, you can now see the difference between a typically developing hip socket that's round and the ball sitting within the socket, and then how the appearance of the hip looks abnormal in the patient with MPS. And then if we look at a patient who's older still, now here's a 25-year-old patient who's a patient of mine who I still see frequently for follow-up. And so at this age now, he has further development of hip issues. Again, the ball is not completely in the socket. Both sockets look shallow. He's starting to develop some increased kind of almost like we would call it sclerosis, or that white appearance to the socket and the ball. At this point now, this patient he's 25. He's still very active in his community, but he's able to walk only short distances, and he has to stop after short distances. He's developing multiple joint issues, as many of you are familiar with. So he has issues not just with stiffness in his hips, but also stiffness in his upper extremities and other lower extremities. And unfortunately, he also has having back issues at this point that's also affecting his function. And finally, he also has underlying cardiac issues, which leads to also difficulty with activities. He gets short of breath with any exertion and things like that. One thing I would say is that these are all MPS type 1 patients. We do see hip issues in the other MPS conditions certainly as well. One thing that's interesting about the MPS 1H patients is we see that the hip issues are very common, somewhere between probably 90 to 100%, depending on which study you look at or how you look at the patients and how you define the hip dysplasia. So it's very frequent in MPS 1H patients. It may vary a little bit in severity. If we look at some of the other MPS conditions, though, like MPS type 2, Hunter syndrome, here's a patient who's age 8, and we see some subtle differences, but not as severe as the MPS 1H patient we saw a moment ago. So at age 8, he's looking actually fairly good. The ball is in the socket. The socket is developing pretty well. But actually, at this patient now at age 12, we see that now actually as he's grown, the hip socket really hasn't continued to develop with the femoral head or the ball. And now we're starting to see that kind of dysplastic or shallow appearance to the hip socket. In Hunter's patients, it seems like the hip issues are not as severe and they're not quite as frequent. So we may see it in some Hunter's patients, but not in all Hunter's patients. Here's a patient with MPS type 4, 4A, Morquio syndrome. Here's this patient age 4. We can see the ball is in the socket. The sockets look a little bit shallow on both sides. But looks like the ball is in actually relatively well. Maybe the left side might be slightly or mildly subluxated. This is the same patient 8 years later, and now we see dramatic changes in the femoral head. With the patients with Morquio syndrome, it seems like one of their issues is they have more laxity of their joints. Their joints are looser than typical joints, also compared to the kids with other MPS conditions. And so we think that may be one of the factors that contributes to the more significant hip issues and problems. But here we can see on the right X-ray, now the femoral head looks dramatically different. We see this white sclerosis again. That means the bone is probably not particularly healthy. We see an area where we don't see the bone forming in the medial part of the femoral head, sort of this kind of like we saw before with that mild avascular necrosis type appearance. Okay? And then also the sockets look much shallower, and we're starting to see sort of early changes early degenerative changes in the hip joints. So why do we think this is important? Well, if we look at the natural history of these patients, first of all, what we find is that, unfortunately, even despite early enzyme replacement therapy, ERT, or even in patients who undergo successful bone marrow transplant or hematopoietic stem cell transplant, the hip issues do not respond. So even with relatively normal physiologic enzyme levels post-transplant, the hip issues persist. Also, if you look back at the early reports of the patients after bone marrow transplant, it seemed like the transplants were successful, but as I looked at those patients long-term, many of those patients still had problems with their mobility and still developed degenerative hip issues as they got older. So even though they might have been doing better in terms of their other physiologic systems, the bone issues persisted. And we know is that for many patients, if they do have persistent hip subluxation that we saw, so that hip where the ball's not pivoting in the socket or the socket's shallower than normal, unfortunately that can lead over time to degenerative joint disease and arthritis, and that in turn then leads to increased joint pain, stiffness, and decreased mobility. Okay, so question number 2. So we have this hip issue. We say we think it's going to lead to a problem as they get older. We think it's going to lead to hip stiffness as they get older. Can we do something to change it? And so as an orthopedic surgeon, I usually recommend, well, here are the surgeries that we would propose or suggest for your child. So what are the goals of our surgery? Basically to get that ball, if you will, the femoral head back into the socket. So if it's partially out of the socket, we're going to get it back in the socket. And then secondly, you want to try to improve that socket so the socket has a more normal appearance. Now, in many things in orthopedics, there's more than one way to approach a problem. So we have a couple examples of different procedures that we've performed that we'd recommend depending on the issue. So on the left, you see the x-ray of a patient who's 5 who had hip subluxations on both sides in the shallow hip socket. So for this patient, they had, I'll go back if I can. There you go. So what we did is, first of all, we wanted to get the ball back in the socket. So the way we do that is we do a procedure where we have to cut the femur bone. We very carefully divide the femur bone. I know a lot of parents start to kind of raise their eyebrows when we start talking about cutting the bones, but what we do is we want to cut the femur bone and just reorient the position of the ball so we bring the ball back down into the socket. So we've divided the femur right at the level right below the hip joint, and then we've put it back together by putting this metal plate that will hold the bone together so it can heal. Then on top of that, we wanted to improve the hip socket issue, so we've done an osteotomy, or a cutting of the bone, of the pelvis bone, to reorient or to reshape the socket. In this case, we wanted to reshape the socket, so we did a procedure where we did a cut in the pelvis bone and inserted a bone graft in here to make the socket rounder. So before it was shallow, now we try to bring the socket down to a more horizontal or level position. An alternative approach to do this is if we have a patient where they have a hip subluxation and the hip is not quite perfectly in the socket, and the socket's shallow. Here's a patient with MPS 1H at age 7. This was a procedure performed at another institution, but I think they did an excellent job. They did a femoral osteotomy again, divided the femur, brought the ball back into the socket, put the metal plate on it. By the way, the plate comes out a year later, typically, for most patients. That's another question we get asked. And then they did a surgery where they divided the pelvis bone up above the socket, reoriented the socket, and then put a bone graft into that socket and held that in place with these 2 metal pins, which also came out later. So they were able to improve the hip socket by doing what we would call an innominate osteotomy. So that's another option. Okay. A third option is, here's a patient who's now a little bit older. She presented to us when she was 11. She'd been treated elsewhere and came to us when she was 11. And so she, again, has the issues of the steep femur, the hip that's not perfectly in the socket, and she has these really dysplastic or really abnormal-looking acetabuli. So the acetabulum on both sides looks very abnormally developed. So in her case, we didn't think we could do the osteotomies to reorient the femur. So in her case, what we actually did was a procedure where we inserted a bone graft essentially above the socket. And this is based on the experience of Dr. McKenzie and his colleagues at DuPont. We looked at the Morquio's 4A patients and inserted a bone graft to try to create a deeper socket or improve the depth of the socket by making the socket deeper by providing a bone graft. Okay. Now, one of the challenges we have is, unfortunately, there's only a handful of really reports in the literature that look at the experience of this. And so if we look back at just some of the more frequently cited articles, 3 of these actually are from the same institution. Has done wonderful work out of Ireland. Our report is, we came out in 2013, looked at our results, and our most recent results are again out of Ireland in 2016, and we'll come back and look at that in just a few minutes. The next question that often comes up is, well, can we do the surgery safely? And so, as I mentioned before, most patients this day and age, and many families, and for my patient, I just need to be doing the same thing. I'd be getting on the internet, I'd be trying to learn about this, I'd try to be contacting their families, find out what their experience is. And pretty quickly, what people realize is that when they start to talk about families, There are certain risks that come with when we propose these surgeries, and I would break these down into what I would term maybe say the typical infections, typical complications, and I'll start off by saying that I've had every one of these complications, unfortunately, in the patients I've taken care of. And so I would say there are typical problems or complications we have with any procedure. So whether I'm doing this procedure or a different procedure, you can have problems like an infection, the hip doesn't heal properly, there's a problem with the blood flow so the ball can't grow properly afterwards. You do the surgery when they're 5, and lo and behold, they come back when they're 9 or 10, and the problems come back again, or we have what we call recurrence. Okay? So we can usually manage or talk about those things pretty comfortably. But the really big issue that's out there right now is this issue of paralysis. And we've had an experience at our institution, and there are a number of other reports out there. Actually, another kind of anecdotal reports of that. And one report in the literature from my colleague, Dr. White, and Dr. McKenzie, looking at an experience they had, and they're the first ones to actually report this. But they identified 2 patients, one of theirs who was an MPS type 1 patient who was paralyzed after their hip surgery. So immediately the next question the parents says, well, if you're doing hip surgery, how is that making my child paralyzed? Or how could that even make a risk of my child becoming paralyzed? And what it says, what we believe is, so what we believe is that there's an issue of thoracic kyphosis, which contributes to putting the spinal cord at risk. The reason why they get a paralysis is not that we've damaged the spinal cord directly. We've never touched the spinal cord, we never even went close to the spinal cord. But in the process of the surgery, if their blood pressure got too low for an extended period of time, it seems like the blood could not get into that part of the spinal cord, and those spinal cord cells then died. It seems like the kids who have a high thoracic kyphosis, so a thoracic kyphosis, that is the bending of the spine, where the spine bends forward, if they have that in the upper part of their spine, it puts their spine more at risk than the kids who don't have that. So if we look at the kids who have MPS conditions, we all know that classically most of them, or many of them, have this thoracolumbar kyphosis, and we're familiar with that. In fact, that's oftentimes the sine qua non, the thing that people identify that's pathognomonic for this. So again, it goes back to this idea that maybe there's certain focal areas where the bone doesn't form in MPS conditions. So this is the thoracic part where the ribs are. This is the lower part of the spine. And so right at the junction, you often get this wedge-shaped vertebrae that leads to this bump on their back, the so-called gibbous deformity or thoracolumbar kyphosis. Now, this is the same patient, but sometimes what you don't appreciate is that in the upper spine, there's the same kyphosis issue. And so the spine is having that same bending forward deformity to it. And so what we found is that if we look back at the patients who, in our experience, we try to identify these patients, it seems like having that high thoracic kyphosis puts that spinal cord at particular risk for a problem with the blood flow to the spinal cord. So this is unfortunately the patient I had who had a spinal cord injury. So what we found is that, pardon me, wrong button. I got my laser and forward pointed, buttons straight here, sorry. So this is the MRI scan of his spine. This is the front where his face is, where his chest and stomach is. This is his back of the head, back of his back. And so he has a really dramatic kyphosis, which we were aware of but didn't appreciate the significance of this at the time. This was a number of years ago. So all these little bones here, this is the vertebra. So this is the bone and the disc in between here. This black part here is the spinal cord. So the spinal cord comes down and takes this abrupt curve right around where that kyphosis is. So there's a really big bend in the bone, which probably even puts more pressure on the spinal cord. So trying to understand why this can happen in patients, what we've identified is there's probably several factors that contribute to it. So I think probably all children with MPS are at some potential risk for this, though in many kids, they've had no symptoms, they've had MRI scans, they've had other procedures, other anesthetics with no problems. But if we have a patient, we're thinking about doing a surgery, sometimes we do the surgery with them lying on their stomach, which we call the prone position. That probably contributes to a problem. That thoracic kyphosis presents an issue. And then finally, having that low blood pressure, either during surgery or even after surgery, can probably put that spinal cord at risk. In my patient, we thought everything was fine at the time of surgery. There's even a note that after surgery, he seemed to be fine and was intact. But then between the time the surgery was done and 24 hours later, there was probably a period where he had low blood pressure for an extended period of time, and that's when the insult happened. So we've developed a little bit of a checklist at our institution that we're trying to use now. And so what we do is first of all, we screen these kids to see who has upper thoracic kyphosis, who are then at particular risk. All these kids get evaluated preoperatively by the neurosurgeons as well to look for any cervical spine issues, such as either instability, especially in those Morquios 4A kids who have a lot of instability to begin with. Other kids can have instability or also stenosis in their neck, where it's really a tight area and there's not much room for the spinal cord. And the other thing we've added, I think Dr. White has as well, and we've talked and communicated before, is that we now do what's called intraoperative neuromonitoring. Now, this is the same monitoring that's done during spine surgery, so it's a very common thing done in institutions that do spine surgery, and if your child has severe kyphosis or severe scoliosis, chances are your institution's already doing this. But now we've taken that and we've applied it to children having lower extremity surgery. And by doing this, what we're trying to do is we're trying to monitor the function of the spinal cord real time during surgery. And if we can identify a risk, we can try then to change surgery or even sometimes abort our surgery or stop it before we complete the entire list of procedures we're going to do, for example. Another thing we'll do is we ask the anesthesiologist to insert an arterial line so they can be monitoring blood pressure real time throughout the procedure, try to avoid those episodes of hypotension. We do it supine, we avoid an epidural catheter, and the kids go to the PICU post-operatively. Very briefly, this is an x-ray in the operating room, so this patient is now prepped and draped, ready for surgery. Before we've made any incisions, we've inserted these little electrodes into their lower extremities, inserted these little wires, and these wires then handed off to a technician who's standing by, and they are monitoring the function of the spinal cord by sending little signals from the brain to the extremities, from the extremities back to the brain throughout the surgery. And lastly, let's talk about probably the biggest question of all. If we're going to do anything, does it really make a difference? Can we change the natural history? So this is our report from about 5 years ago when we looked at our experience, and we had approximately 50 patients with MPS. 20 had had surgery, 31 had not had surgery, either because they opted not to have surgery or they're still young enough that we hadn't considered surgery for them yet. And what's interesting was if we looked primarily just at radiographs, and in truth, this is just based an X-ray-based report. We looked at our X-rays, we compared X-rays on kids who had surgery, who didn't have surgery, and the X-rays looked better, okay? Better. However, I will certainly point out that we did not have any functional outcomes to report. So we were not doing routine functional outcomes testing. We didn't have any questionnaires that they were filling out. One maybe way of looking at that was we did look at our patients who had hip problems later, and in truth, the patients who had surgery did slightly worse than the patients who did not have surgery. We actually had more patients who needed a hip replacement in the surgery group than the patients who had not had surgery. So if that's sort of a factor, if that's one kind of way of looking at it, I'd say that at this point, we still haven't shown that our surgery is making a difference. I mentioned the article out of Ireland by Dr. Kennedy and Dr. O'Meara et al., and they have an excellent report. That's probably our best report as far as looking at the long-term results, and they came out with their report 2 years ago. And they looked at approximately 26 hips, if you will, so each patient had hip surgery. There are 13 patients. And they had probably, first of all, the longest follow-up that we've seen. Their average age was 18 years of age. And what they point out was many of their patients, even though their x-rays looked good and the hip was in the socket, they still developed problems over time. So the Harris Hip Score is one way of giving patients a questionnaire and asking them how they're doing with regard to pain, with their function. Effectively, 100 would be kind of typical. So if you're walking with no pain, you can do all your activities, normal living, that'd be 100. Their average age was 61, but their range is all the way down to 19 to 91. 4 of their patients were using either a wheelchair or a walker. And even though the hips look good on an x-ray, already 10 of their 26 hips, almost probably about 40%, had significant degenerative changes, even at age 18 on average. And then finally, my colleague at the panel here, Dr. Eastwood, did a wonderful review of kind of the orthopedic issues, looking at all the various orthopedic issues in the upper extremity, lower extremity, spine, hips, knees, and I think she makes a terrific conclusion is that at the current time, our functional outcomes do not support early reconstructive surgery. So if you look at the data we have, if you look at the literature, you try to have a conclusion from what we have out there, we do not have yet the functional outcomes to support early surgery. Now, one of the issues I think is that we don't quite totally understand why some of these kids develop some of these long-term issues. So if we get the ball back in the socket, why is it not developing well? Why do these children still have issues or problems with their mobility and things? And I think it comes to several different issues. One is many patients do have significant joint stiffness, and that's in multiple joints, again, in the upper extremities and lower extremities. Part of that may be the joint itself. Some of that may be the soft tissues and areas around the joints. Many patients do have, it seems like, significant weakness. They develop pain over time, and many of them do have decreased endurance over time. And I think one of the future issues we're trying to look at our institution is like, well, which of these procedures is the best one? And I mentioned that we do a number of different procedures, and there are different options for doing it. So this is a patient of mine who is 6, was having surgery. And so this is preoperatively, so we see the ball's not completely in the socket. The socket, again, has that abnormal appearance where there's kind of the outer part that hasn't completely formed. So we've done the surgery on the femur bone. We cut the femur bone. We brought the ball back in the socket. We put the plate on. And now we've done what's called an arthrogram. And this is where we put a needle in the hip joint in the operating room while the child's still under anesthesia. Pardon me. We inject a liquid that will show up as black on the x-ray. So on this image, this black part is liquid in here. So we can see the outline of the ball right here, and we can see the outline of the socket right up in here. And actually, in fact, here's the cartilage socket, and the socket actually has a very good shape. So the socket doesn't look, if you look at the cartilage and that part that shows up on the arthrogram, we see parts there that you cannot see on the regular x-ray, okay? So the socket has a pretty good shape to it. So if I start thinking back and say, well, if I'm doing osteotomy, I'm going to cut the pelvis bone and I'm going to change that socket, is that going to make the socket better or worse? So we have to look at what is the best way to try to improve that acetabular dysplasia, and I think we still don't quite have the information or literature to know for sure. Certainly, we know there's a lot of different ideas that we're trying to look at in the future. Certainly now the role of early diagnosis and treatment, as we see more and more cases going to newborn screening, I think we're going to see more and more young patients. I do have just a few anecdotal reports of a couple patients, again, who are like the younger sibling of a patient who was born first, an older sibling was born, has an MPS condition, younger sibling is born, they get tested at birth, diagnosed early, started right away, early bone marrow transplant, maybe at 3 months of age. And unfortunately, even in those early patients, in our anecdotal experience of just a few patients, it seems like the orthopedic issues still persist. So right now, it doesn't seem like the early treatment has shown ability to change that yet, but we're still looking at that. And our numbers are so small, we can't really draw any major conclusions yet. Certainly know that with many kids, even with enzyme levels, they have GAG deposition in the soft tissues, and it seems like there may be this role for chronic inflammation as a function of the GAG material itself. It seems like maybe for some patients, the GAG material itself incites a chronic inflammatory response, and that itself may also lead to some of these joint issues. So I would say, in conclusion, as we look at the future, we need to have, we need to know more about the issues. We need to kind of understand the natural history better. Ideally, we'd have better functional outcomes to know if our surgery is making a difference, and how can we look at what we've done, and how do we look forward to the future and chart the future from here. So I think we've done a great deal. We unfortunately know that the hips don't respond to the early bone marrow transplant enzyme replacement therapy yet. I talked to a mom just recently, and I said, yeah, unfortunately, I think we're still not at a point where we can truly make the hips normal with our surgery. And she said to me, says, yes, but maybe you're making them better. So I think we still have a long ways to go. So it's kind of a journey, and we're not there yet, but hopefully with future meetings like this, we'll share information, and more is yet to come. So thank you very much.